my name is Dr. Brian Cooper, and I'm the electrophysiologist for the hospital, so heart rhythm specialist. And when you look at the heart, it's a mechanical, electrical kind of pump. All right, so anyone who's a plumber or electrician in the room or any of this sort of thing, you can almost think of the heart as the same kind of way. It's got an electrical component to it that gives the heart its coordination to move blood, because in essence all the heart is just a pump, and it's got to move blood from one place to another. And so I help take care of issues that come up when it goes out of whack. So we're going to talk about sudden cardiac death, and what is sudden cardiac death? Basically, as it sounds, you die all of a sudden because of something that happens with your heart. It's usually a heart rhythm issue that comes up. Two terms that we talk about a lot, something called ventricular tachycardia and ventricular fibrillation. They're kind of like cousins to each other, but these are the two probably most common reasons why people will die suddenly from their heart. Just to start out with the basics, everyone sees EKGs. As cardiologists, we see them all the time. If you get one, this is, in essence, a really boring EKG. I mean, this is what someone's normal is supposed to look like, okay?
It's not boring to me, Brian.
So, to me, it's, this is normal, pretty much normal. There's lots of variations to what is really normal, what's not normal. In this case, the machine, the computer actually got it right too, so it's a normal EKG. You can see the difference between this EKG versus the other one. And, just to show you, pretty normal. And then that's just, it's organized, but it's kind of out of whack. I mean, anyone who sees this, you probably can have an idea that it might not be normal, something's wrong. This is what we call ventricular tachycardia. This is when someone's heart rate's going really fast. The rhythm here is probably going about maybe 70 beats a minute or so. Maybe a little slower than that. This one is traveling at probably 250 beats a minute, so it's going pretty fast. So you can imagine if you're standing there and all of a sudden your heart takes off at 250 beats a minute, what you might feel like. This is the other one, ventricular fibrillation. So it's really hard to catch this on an EKG, because usually if you're doing this and you catch this on an EKG, the person's dead. So, they're going to get a shock very quickly after this happens. But here you can see it looks like the start of the normal EKG, and then all of a sudden it just disorganizes and goes into disarray, and you can't really tell anything from that. So that's what that looks like. All right, so what are the causes from sudden cardiac death? And heart attacks can do this to people. After you have a heart attack, that's when people are at risk. This can happen. So you come in with a heart attack, say you're having a big one, you clutch your chest like, Elizabeth, I'm coming, and then you get into the hospital, they open your artery, and then everything's fine. 2 or 3 days down the road, you have an arrest in the hospital, and people are wondering why. Wasn't your artery fixed? Didn't they open the artery? You didn't have your heart attack anymore. They fixed you. Well, this can happen after a heart attack also, which is why people stay a few days after they've had a heart attack, okay? Because within the first 48 hours, 24 to 48 hours, after you get something done to you, you can have all of a sudden one of these dangerous rhythms come up. This term called cardiomyopathy is when the heart is abnormal for a number of different reasons, many causes for what's a cardiomyopathy. Genetic disorders can make people die suddenly. Usually this happens in the young people. Okay, you can live to young adulthood, so that way you're able to pass it on to children, but then all of a sudden somewhere in their 30s, 40s, and 50s they collapse all of a sudden, and it's not from what we call a heart attack, from a closed artery. And then there's some things where your own body attacks you, and then can give you issues with your heart, and you end up with sudden death. And as Dr. Few told you before, you're going to see one of these, right? So I throw one of these up here as well. Basically, you have risk factors for this: how old you are, if you have high blood pressure, diabetes, if you smoke, if you're big, kidney disease, inflammation for all kinds of reasons, your genetics. And you could develop this heart failure, or you could develop heart disease from the arteries of the heart. We call this coronary heart disease. When you have this, you get heart attacks, you get scar in the heart, decreased blood flow to the heart doesn't function the way it's supposed to. And this side, if it's not from artery disease to the heart, and these other things give you what we call the cardiomyopathy, or abnormal heart. This alters a lot of things within the heart, which we won't get into. And then all this feeds into here, which are basically triggers for ending up with sudden death. So, any of these things, whether it's arteries that give it to you or these other risk factors where your heart just gets dilated, it's big, it's abnormal, it's scarred in, can give you these triggers and you can end up with sudden death. All right, so a lot up there is hard to read, but looking at two different pie charts basically for what men and women die from when they have sudden cardiac death. So coronary artery disease or artery disease of the heart gets men a lot more. About 80% of men will have this problem as a cause for their reason why they die suddenly. This is called dilated cardiomyopathy. So this is the other reasons when hearts fail. It's not from the arteries of the heart. And then some of these other kind of issues. And some people, their hearts are normal, yet we don't know why they die suddenly. And then for women, they're catching up somewhat. This number is probably more like 50% from artery disease of the heart. Women can have a little more of this dilated heart disease, and then a lot of other kind of causes. And then again, even in women, there's normal hearts that we don't know why people die suddenly, but they collapse when they die. So, what's the rate in the United States? It's always hard to figure this out. I mean, this is a big number, right? 180,000 to 450,000. It's a big range. I mean, you're kind of guessing when this happens. Sometimes, depending on who this happens to, it might be too late. This person's passed away, and they show up at the hospital, and you're trying to figure out why. And then usually through talking to family, through history, you decide, did they die from a heart attack at home, or some other issue, or was it something else? So it's always difficult to really know what that number is. So with sudden cardiac death, more than 50% of all these cases are caused from coronary heart disease or artery disease in the heart. Okay, that's about 50 to 20% of most of those. Okay. Looking at the spread of which one does it to you, this ventricular tachycardia, so that very organized but very fast EKG I showed you. The one that's very disorganized is about 8%. Believe it or not, if your heart rate gets too slow, it can get slow down, and stop, and then people die suddenly from that sort of issue. And then this thing that the French first described is called torsade de points, or turning of the points. It's kind of like a mixture of this one and this one together, and believe it or not, this one could be a trigger to this one. So it's a very complex kind of a thing. But in essence, these are the different, this is basically just shows the majority of people have this one particular rhythm, and then these make up the rest of them. So who survives? Not a lot of people, unfortunately. Say you were to have a heart attack from artery disease of the heart, or you collapse from a dangerous rhythm of the heart, for whatever the reason. When they find you, and you're actually able to get a blood pressure back and a pulse back and make it to the hospital, only about 8% of these people are ever going to walk out of the hospital again. Okay? So that's 8 out of 100 that show up who might be dead. Alright? So it's not a good thing to try to take care of. If this happens to you while you're in the hospital, 15 to 30% of those people might walk out again. So you think, oh, I'm in the hospital, if I have this rhythm issue, I should be taken care of. If they should take care of me, it should be okay. But it really cannot be. Okay? And this number is basically just walking out of the hospital again. Some people will survive, but then you're on what no one really likes to be on, life support for the rest of your life. You end up in some of these facilities that you're on a permanent ventilator or something like that. So quality of life kind of weighs into some of this. But if you're going to leave the hospital normal again, only about 8 out of 100 people who show up who have sudden death. All right, so just looking at the structure of the heart, because it kind of helps to see. This is, in essence, a normal heart. The main pumping chambers are the ventricles, which are down here. Up top, you have what we call the atrium, which are just these reservoirs or filling chambers. This is the right side, that's the left side. The right side pumps primarily out to your lungs. The blood returns from your lungs into this little filling chamber, goes to your left heart, and then the left heart pumps out the whole body. In our field, a lot of times we ignore the right heart. Most of everything we talk about is about this left side heart, which pumps your whole body. So the main arteries that go to the heart, that they always put stents in and try to, open blockages and whatnot. Everyone's focus is usually on the left heart. In my world, you never forget about the right heart, though, because this could be a source of a lot of problems. This is just a view of your heart's wiring, in essence. Okay, so we all have a natural pacemaker. and that lives up here in the top little right chamber. All this does is this just initiates your heart rhythm. So the little cells that are up here are excitable. They decide to activate themselves. They give an electrical impulse, and there's electricity in here. I mean, we can measure the amount of electricity that happens, and it travels down to this one connecting point. And if this connecting point is the only thing that connects the two bottom chambers here to two upper chambers, electrical activity will travel this direction to get to the top little chambers, gets to your connecting point. It comes down these two, what anatomically look as if they could be wires, and they're covered with like a sheet, so there's like a coating to it. And it travels very fast down, and then exits out to your right and left heart. And that gives you the whole left up, that's the coordination. It starts, they contract first, gets here, there's a bit of a delay, shoots down here, and then the bottom contracts after that. Looking at what heart tissue looks like, so this is what a normal healthy muscle looks like. It's very organized, if you can make it out. Long lines of just heart muscle, all right? And so I like pictures, so I like showing a lot of picture stuff. Again, close up, very organized, linear heart muscle, okay? These lines in between here, these ones that go perpendicular, that's the connecting point from a heart cell to heart cell, and these actually are what allow the heart to keep an electrical signal traveling. There's these connections in between this that just allow electroactivity to go. And it's a very, it's a complicated wired system, but in essence, that's the way it looks like when it's normal. So when you have a heart attack, what happens to you? This is what Dr. Pugh was showing you a little bit of. This is what an artery looks like that's filled with this blockage. All right, so this is the blockage. The hole should have been like this, but now it's narrowed to this. And in this one, it's even more narrow. Okay, all right. So when those happen, people end up with this, what's called a heart attack. So this is a heart that's been cut open in this section. This is the right heart, which is smaller, it's a thinner muscle. This is the left heart, which is a bigger muscle. And it's supposed to be red, like this, look like muscle tissue. This is the scar that we form after a heart attack. This is completely dead. This is scarring, and the scar tissue that fills in when your body's trying to heal itself. So it's almost like a scab inside the heart. This is what is a setup for the sudden death. And in essence, rhythm issues come from this after a heart attack, not just from when you have the heart attack, because when the scar sets itself up, now the heart tissue that was able to conduct electricity, it can't get through this because it's dead. And then see this little channel here? You get these channels that go through that might be still alive. And then as your heart gives a normal pulse or a normal rhythm, when it hits this area, that signal or electrical activity can get delayed. It travels through here slowly, it can exit the other side, and then this tissue is ready to be stimulated again. It hits that, it circles around, comes back here, makes its way through again, circles around, makes its way through, and then you go into this issue that just sets you off in a rhythm that is fast, it can be dangerous, and then people die suddenly. That's how it works with a heart attack in essence, okay? Here is the picture of the heart tissue again. This is supposed to be healthy. This lighter pink stuff is the scar that's set up in here, okay? And you can imagine, you're getting an electrical impulse that comes down, it's traveling through all these heart cells, and it gets here, and it kind of slows down, and gets sluggish through there, and then it's able to exit here and come around, all the way around again, and circles around these scars. And that disarray is what sets you up for having a heart rhythm issue that causes sudden death. This is like that other slide I showed you. So now this is completely destroyed. That's a heart cell here, this is all fibrous, scar that's in between it, and this is what you see after a heart attack. All right. One thing I want to talk about before we get to that also, in people who have heart disease, heart failure, this cardiomyopathy term that we use where the heart fails for another reason, when it's not a blocked artery or not the heart dying itself, you get scar like this, it's not as extensive, okay? So it kind of gets scar that kind of fills the area because the heart's getting bigger and bigger. For whatever the reason it decides to fail, it's trying to accommodate its failure by compensating. And it compensates by filling in, not with new heart cells, but with all this scar stuff. And that also sets you up for these dangerous rhythms. So they're similar, but they're different. All right, the other one I want to talk about, which you're going to hear a lot about artery disease, the heart, and all those sort of things. That's more the plumbing side. I'll leave it to the plumbers that I work with. Since I'm the electrician on the electrical side, I like these other things. They make a little more sense to me. Genetic disorders that happen. So the heart attacks that give you the scar and that people have blocked arteries, that happens in people with risk factors. They're older most of the time. They smoke, they have high blood pressure, they have diabetes, they have all these things that can lead to developing the plaque in the arteries and having a heart attack. The genetic disorders that come up that give people sudden death, they're younger people, they may have not seen a doctor, they have no reason to go get a physical because they feel like, oh, I'm healthy, I don't need a physical every year. And there's different types that come up. This one's called hypertrophic obstructive cardiomyopathy. You got long QT syndromes, something called arrhythmogenic right ventricular dysplasia, or ARVD for short. And then this other one is called Gauda syndrome. There's other types of syndromes that come up. These ones that we see, the genetic disorders, are usually the younger people in their 20s, 30s, 40s that can die suddenly. This hypertrophic cardiomyopathy, it's a common one. This EKG, it's nice if we see this in someone that come in, maybe they're having a little bit of chest pain, or they come from physical, we see an EKG that looks like this. This is the EKG of someone whose heart muscle is too big, and it's not too big because of high blood pressure for a long period of time. It's too big because this is a particular genetic disorder that comes up. What happens is part of the heart gets too thick, and if you look at it close up, the heart cells are in disarray. Not with scar, they're just in disarray, they don't line up properly. And that's just it's a genetic disorder that comes up. For whatever reason, with that disarray, then you're set up for a sudden death at some point. Okay, but usually what we find is someone has an EKG like that. They get an echocardiogram, which is a very simple test to do, and then you can see this on the echocardiogram. And then you do genetic testing. You ask questions. Has anyone in your family had any issues like this? Has anyone died at a young age? And that's how we find these people. This long QT syndrome. This is another type of disorder which we diagnose with EKG. You're going to notice a recurrent theme in here when it comes to some of these genetic disorders and how we try to find some people at risk for sudden cardiac death. So this is an easy test to do. It's an EKG. Everyone gets an EKG. I saw this. If I see this, I tell them, all right, well, you have long QT syndrome number 1. Basically what we look at is from the start here, from the start here to the end of this other wave here, there's a certain time that we allow for that to happen. If it gets too long, then we actually call you that you have this long QT syndrome. The Q wave is this part over here, the T wave ends over here. It's a particular syndrome that we know that can be out there in younger people. This type 1, your EKG looks like this at rest. Sometimes it looks almost normal at rest. If you exercise, this prolongs and gets further out. And when this wave pushes further and further out, you're set up for a heart rhythm issue. That one that I mentioned before, this torsades de pointes or ventricular fibrillation, it's sudden death. So as these people exercise, they can actually die suddenly during exercise. So the basketball players that drop all of a sudden, soccer players that drop, those kind of things. You like to do an EKG on these, sometimes kids, to see if they have this before they do sports, because you don't want them to all of a sudden die while they're playing. So that's that particular one. There's another one, long QT syndrome number 2. This one's very peculiar. Again, the wave out here is pushed out far. It has this double bump to the end of it, which is nice if you see it. And this is also another person who would be at risk for sudden death. This particular person, the risk is not as much with exercise. This one's pretty fascinating in the fact that the story that you hear sometimes is that they were found dead in their sleep or in their bed. They were found dead at the front door, maybe next to a telephone or something. Long QT syndrome number 2 is mainly set off by an auditory stimulus. So something rings, and all of a sudden their heart goes into an arrest and they die. It's very unusual. Someone could just ring your doorbell and all of a sudden they drop dead. Their alarm rings in the morning and they die in their bed. It's very peculiar. No one really knows why an auditory stimulus, a hearing stimulus, sets this off, but it can happen. So it's kind of scary to think of this one. It's hard to pick these people up sometimes because they're found dead most of the time. Long QT3, another type of syndrome like that. Again, same idea. This wave pushes out too far. EKG has a certain pattern to it when you see this. This is harder to pick up. This one's even harder to find in people because these are the kind of people that die in their sleep. So at rest is when you go into an arrest, all right? They can exercise, they don't have any issues when exercising, but if they sleep at night, all of a sudden they just go into an arrest and they die. So it's a very, like I said, the three of these, what we call long QT syndromes, are very unique syndromes. The issue is there's a protein in the heart that's in your heart cells, is how you can conduct electricity, and the function of those proteins get altered by whatever you inherited from your family. And usually family history is most important for these because we're asking, has anyone in your family ever died suddenly at a young age? And this is what we start to look for, okay? Because it's very unusual to die in your 20s, 30s, and 40s, all right? And so usually the way we treat these, everyone keeps thinking of the treatments for these types of things, how you're going to prevent this. These three syndromes are usually treated by medicines, all right? This other one called ARBD for short, if you want to say this, you can. That one has a particular look of the EKG also, all right? So the EKG is altered. For those of us who know what we're looking for, we look for the certain patterns. This is another one that actually affects people younger age again. Usually athletes, you're screening people who are playing sports because this one will also get you when you exercise. So if you exercise, you're set up for sudden death. When we get a heart MRI, what we look at is this is what the normal muscle looks like. This is what the muscle looks like with this particular syndrome. It just lights up a different way on the MRI. Here it is again, lights up a different way on the MRI compared to what the rest of the heart looks like. What happens is this is the heart muscle cells, and all this is fat cells. And for some reason, fat cells start filling up the heart muscle, okay? And it just sets you up, again, same idea, this electrical disarray that you go off in these dangerous rhythms. Brugada syndrome is a very unique syndrome. It was first described by this physician Brugada. This is another one that causes sudden death in people when they're young. It's inherited. You can inherit this from your parents. You can also gain this just by having a mutation in your own genetic code. This is supposed to be extremely rare. It's hard to find these people, yet for some reason at Erlang we found 3 of them in the first year I've been here, so it's very uncommon. You should see one of these in your entire career. An EKG pattern looks like this. These people get misdiagnosed by an acute heart attack. They think that they're found on the ground or something, and they come to the hospital, they get a pulse back, the EMS does CPR, they're saved, and they see this on the EKG, and they get run to the cath lab, or they get a catheterization, thinking the artery is blocked to open an artery. But when I see this, you pick up on the pattern of it, like, this is not a heart attack, this is a genetic disorder, okay? And then basically, in essence, what this one will do to you is another one just like the other syndrome I mentioned. These people can exercise. There's usually not a problem with exercise. Day-to-day life does not really bother them. This is another kind of person that at rest is when you're at most risk. So for some reason, when you're resting or in your sleep, these people tend to die in their sleep. Okay, so that's why it's so hard to find. If you actually survive and make it to a hospital, we see this EKG pattern, then we talk about what treatments we do after that. So improving survival, how do we improve survival? Well, you basically want to be preventative, try to control your risk factors. So risk factors for one form of sudden cardiac death is when you want to prevent heart attacks. So change your diet, exercising tends to help, the usual things that you'll hear throughout the whole day. That's for the artery disease side, we develop blockage, that sort of thing. That's what helps prevent at least some of these. The other part is the supportive care. Anytime you come across someone who collapses suddenly, someone who's on the ground, they've been found on the ground or something like that, any CPR, and early CPR is good. Even if you don't know what you're doing, just get on their chest and start shoving on their chest, pushing on their chest. Anything will help. When I was in Massachusetts, there was a very large man who collapsed in his bathroom, and his wife is a very small woman, and she just started pounding on his chest, just pushing as hard as she could. And he survived to the hospital, and he walked out again. So, anything you can do, early CPR is about the best thing you can do, even if you don't know what you're doing, even if you haven't been trained. Just put your hands on their chest and just start pumping, and that will help most people. And then we got other prevention, which is these implantable cardiac defibrillators. Okay, these are wonderful devices. They decrease your risk of dying suddenly, but they're not without their problems. That's why not everyone gets them. Alright, so there's all these trials that have been done to help to figure out do these devices really help people. I don't want to get into all that, but these are the ones that we tend to reference all the time. This is what they look like. A pacemaker is a similar kind of device, which is for heart rhythm only. 2 wires usually sit inside the heart and the right side of the chambers. And a pacemaker, all it does is prevent you from going too slow. These defibrillators are a little different. They're bigger than the pacemakers will be, although the picture, this picture is kind of wrong. But anyway, these are usually bigger. They usually have 1 or 2 wires, maybe 3 wires to them. And the difference between the pacemaker and defibrillator is that the wire that's in your heart is a shocking wire. It's able to deliver a shock in this direction usually, from this generator to the wire to generator. In essence, like the paddles that you see on TV, people clear and they shock each other. That's what this device does. And it's internal, it's with you all the time, and it's always scanning to see if you go into a fatal heart rhythm, and it will shock you out of it if it needs to. This is kind of an X-ray of what one looks like in someone's body. This is the generator that sits up in the upper chest. Wires enter a vein that's under your clavicle. The vein travels all the way down to the heart, and then these wires go into the heart in different locations. This one's up here in the top little chamber, replacing the heart's natural pacemaker. This one's down here in the bottom chamber. This particular device is a treatment device to help with people who have heart failure. This goes out to the left side of the heart. And there's another pacemaker wire. This bright wire here looks different than the others. This is what you shock from. So this can deliver a shock between these two, we call them coils, on the wire, or it can shock this direction, back and forth, okay? And this is where at one point around the break and show you guys one of these in action.
Als Roeselaar-verdediger Anthony van Loo plotseling in elkaar zakt en voor dood blijft liggen.
Ik ging achter die bal aan, maar ineens voelde ik het niet goed. Ik greep naar mijn hoofd en in 3 seconden lag ik neer, zo gezegd. En dan weet ik totaal niks meer van de wereld.
Je lag er vlak en een seconde of 3, 4, misschien 5 seconden nadien, een shock, je werd praktisch aan de grond.
Die schok is de defibrillator die de prille 20,5 jaar geleden liet implanten vanwege een erfelijke afwijking aan de hartspier. Bij een hartstilstand reanimeert het apparaat bliksemsnel.
Dan ben ik naar het ziekenhuis gegaan en dan was hij terug prima. Ik voelde niks meer, dus de defibrillator had zijn werk gedaan.
Het wonder is door het fit.
When you look at it, this is what happens. I mean, it's sudden. You're walking, nothing's wrong with you, and then all of a sudden you just collapse. And that's what you'll see. I mean, it's instantaneous. People who don't survive this, I mean, there's no pain, there's no suffering. You don't know. You're done. You're gone. And so what ends up happening is, with the defibrillators in place, you'll drop on the ground from a fatal rhythm. The defibrillators nowadays that we have try to treat you first. They pacing the heart to try to break up a rhythm while they charge for a shock, and then they shock you when it doesn't work. And then once it shocks you, the treatment of this is so quick and so instantaneous. This is why people can recover and stand up as if nothing happened. Okay? Most of the time that this happens, a lot of people have a defibrillator implanted in them. If you run and get an AED, I mean, there's time to get the AED, people are doing CPR, they put the pads on you, the device analyzes you, then it shocks you, it has to shock you. Sometimes people will wake up after that. Most of the time they don't, that's when the ambulance will get them and you go to the hospital. But these people have these defibrillators implanted, they work so quickly that they're pretty good at preventing really bad things from happening because they just intervene with you so fast. So that's how one of these defibrillators work. One last thing I want to mention quickly because I'm running out of time. This is a different type of defibrillator. This is new. This one was studied in the last 5 years or so, maybe a little longer. This one, instead of sitting up here on your chest, is on your side, towards your back a little bit. And this wire is outside the rib cage. It's deep under the skin along the ribs, but it's not within the heart. This particular device has only been available nationally for within the last year. Erlanger has put so far 4 or 5 of these in this region. We were the first to do it in this region. I think we had the 3rd implant in the state of Tennessee. Part of the reason they brought me from Philadelphia down here is because I did these things as well. The beauty of this device is that if you had issues with infections or things, people who have implanted defibrillators within the heart, you can infect your heart valves, you infect the heart muscle. They're really hard to get back out again. This particular one, since it's not inside the heart, If it gets infected, well, treat with antibiotics, they might get better. If you have to remove it at all, it's very easy. You just kind of take the generator out and just pull on the wire and it comes right back out of the person. All right. So a little bit different device, but same idea. It's another implantable defibrillator that people keep on them. This is a patient of mine that I had in Philadelphia who had this put in. Unlike, I don't know if anyone's seen people with defibrillators, you usually can see like a bump or a can or a bulge that's up here where the generator sits. This particular one, the generator's over here, and the wire runs across and up, and it's and like that. Some people like this one better because if you're bigger, you can't really see it. No one knows you have that in you. How good are these ICDs? They can decrease mortality by 54%, rhythmic mortality by 75%. So they help a lot. Okay, so you know people who qualify for these implanted devices, they do survive when they're put in. All right, they have a really good effect on your mortality. Again, like I said, they're not without their issues though. The main problem with defibrillators are infection. That's what we really worry about because when they're implanted in the heart, they can infect your heart valves. Other things too, when people who are inexperienced in putting these in, you can perforate the heart with the wires, and the wires end up in your lung. That's not where they belong. Yeah, and that's the majority of the issues with these devices. And then the last thing to speak about defibrillators, they're great. They sound like they're miracle tools, and you know, why doesn't everyone just walk around with a defibrillator? Well, as I said, they're not without other issues. Young people, when you put a defibrillator in them, it's really hard to manage it because a young person can get their heart rate up pretty quick when they're exercising. And even though you tell them they shouldn't exercise because of whatever risk they may have, some people don't listen and they're still going to do it. If your heart rate gets up fast enough, the way some of these defibrillators work is they look at your heart on how fast it's going, and if it gets too fast, that's when it decides to treat you. So you hear some of the horror stories of people who have defibrillators put in, and some of the doctors program them the wrong way, where they put their settings, as we call them, quote unquote, too low. And every now and then you hear stories of people who are running a treadmill for their daily exercise and they got shocked by their defibrillator and thrown off the treadmill, okay, when they're perfectly fine. And of course, when we look at the device, we see that they were shocked for just regular rhythm going fast because they're exercising, not because they had any dangerous rhythm. So, you know, they're great, they work wonderful, but as I said, they're not without issues. And that's, as I mentioned to Dr. Campbell, you know, we're very careful with who we select and who we give these things to. Yeah, that's basically sudden cardiac death, if I had to put it all together.